everyone. Thank you for joining us today for the webinar, Tailoring Tobacco Cessation Interventions for Special Populations Served by Federally Qualified Health Centers. My name is Aubrey Villalobos, and I am the Comprehensive Cancer Control Director at the George Washington University Cancer Institute. Before we get started, I would like to take a few minutes to go over a few housekeeping remarks. We ask everyone to keep their phones on mute and off hold to avoid any background noise and disruption during the program. Also, today's program is being recorded. You will see a few pods at the right of your screen. You can chat with us or one another using the chat pod at the top. If you think of any questions during the presentation that you would like to ask Ms. Krautwurst or Ms. Pratt-Chapman, please feel free to submit them in the question and answer pod throughout the webinar. We'll wait until the question and answer portion of the event after the presentations to review submitted questions. There's also a files pod and a web links pod towards the bottom of the screen. These contain relevant links and resources. A PDF of the slides from today's presentation is also available for download. Today's webinar will cover tailoring tobacco cessation interventions in special populations, including individuals living with HIV, lesbian, gay, bisexual, transgender, and queer questioning individuals, homeless people, and African Americans who all have documented unique needs related to tobacco cessation. Feel free to live tweet us throughout the webinar at GWCancerInst using the hashtag CompCancer. Now, I'm very pleased to introduce you to our speakers. Our main speaker today is Mandy Pratt-Chapman, Director of the George Washington University Cancer Institute. She is responsible for strategically planning and implementing prevention, community health, patient navigation, and survivorship programs, as well as all fiscal oversight and management and development for the Institute. She is principal investigator for a Centers for Disease Control and Prevention funded cooperative agreement providing technical assistance to comprehensive cancer control programs across the country. She established the Center for the Advancement of Cancer Survivorship, Navigation, and Policy in 2009, a nationally recognized training center building capacity and setting the national standard for patient-centered programs. She is co-principal investigator for the first ever study evaluating the impact of cancer survivorship care models on patient outcomes, and she's devoted the past 4 years to creating a safety net for over 8,000 patients in Washington, D.C. as principal investigator for the George Washington University Avon Safety Net Program and the D.C. Citywide Patient Navigation Network. She also hosted GW's inaugural Access to Care Summit in 2015. I'd also like to introduce you to Amy Krautwurst from Whitman Walker Health, who will provide an overview of the Whitman Walker Health Clinic, the population served, and describe the clinic's tobacco cessation program before Mandy Pratt-Chapman discusses population-specific recommendations found through literature review and evaluation of Whitman Walker's program. Amy Krautwurst is a licensed independent clinical social worker, having earned her master's degree in social work with a specialization in clinical health care from the Catholic University of America in Washington, D.C. She currently serves as the manager of wellness programs at Whitman Walker Health. In this role, Amy oversees wellness services including Reiki, yoga, therapeutic massage, meditation, acupuncture, physical therapy, nutrition counseling, diabetes self-management education, smoking cessation, and Whitman Walker Health's Breast Health Initiative. She also manages 2 Debbie interventions, healthy relationships and self-help in eliminating life-threatening diseases, and the +1 peer mentoring program. In addition, Amy works as a volunteer mental health provider with Whitman Walker Health's Behavioral Health Department. Amy, thank you so much for joining us today. I will turn it over to you.
Good afternoon. I'm delighted to introduce Whitman Walker Health. We are a nonprofit, community-based care provider in Washington, D.C. And to really fully appreciate who we are today, we have to start at the beginning of our story. Our roots lie in the groundwork of the LGBT civil rights movement of the late 1960s and early 1970s, and that the precursor to Whitman Walker as we know it today was founded in 1973 as the Gay Men's VD Clinic, which operated in the basement of the Georgetown Lutheran Church and was one of several volunteer-run gay men's VD clinics around the country that would eventually grow into larger LGBT health centers. Our first full-time staff was not hired until 1976, and Whitman Walker Clinic was officially chartered on January 13th, 1978. The experiences of our namesakes, Walt Whitman and Dr. Mary Edwards Walker, are reflective of Whitman Walker's ongoing dedication to meeting the needs of the gay, lesbian, bisexual, and transgender community. And it's important to note truly that the advent of the AIDS crisis and its devastating effects in Washington, D.C., which followed the incorporation of Whitman Walker by just a few years, certainly drew another parallel to both Whitman and Walker's wartime experiences. And with the onset of what we now know as HIV and AIDS, Whitman Walker did emerge as DC's first responder and has been since then a community leader in fighting HIV and AIDS by launching the AIDS Education Fund back in 1983 to provide information, counseling, and resources to those affected and infected with the virus. And this is really, an important part of our history because it's where our early identity as an HIV service organization got started. Whitman Walker Clinic then changed its name to Whitman Walker Health in 2011, which spotlighted our organization becoming a full-service, best-in-class health center. And just in 2013, we did receive full federally qualified health center designation from the U.S. Department of Health and Human Services. And just a very few short months ago, we opened our brand new state-of-the-art medical home at 1525 14th Street Northwest back in May on the 18th. And you can see it right there on the left. It's beautiful. I encourage anyone who's in the area to stop by for a visit. It truly is a sight to behold. And our mission is very straightforward. It's to be the highest quality, culturally competent community health center serving the greater Washington's diverse urban community, including individuals who face barriers to accessing care. So some of those special populations that Aubrey mentioned, and we do have a special expertise in LGBT and HIV care. And services in each of our 4 locations include primary medical and dental care, nutrition, mental health and addiction counseling and treatment, HIV education, prevention and testing, medical adherence case management, youth services, integrated wellness services, and legal services and insurance navigation, which is especially important for folks who do face some of the barriers to health care that we're going to talk about later on in the presentation. So, who do we serve? We talked about where we started and who we are today. Who do we serve? We serve anyone and everyone in the D.C. area who is in need of health care. Back in 2014, we cared for approximately 15,000 individuals, and although the majority of our patients reside in Washington, D.C., we do care for people living outside of the district, with 15% of our patients coming from Maryland and 11% coming from Virginia. And as you can see, we do have a nice diverse population as far as demographics related to race and ethnicity, and our patients who come to us from Washington, D.C. are spread out across all 8 D.C. wards. Although we do have special expertise in LGBT and HIV care, we provide care to all individuals who need whether medical care, dental care, mental health or addiction support, public benefits and insurance navigation, and we certainly do not turn anyone away due to an inability to pay. A big misconception out there is that we only care for LGBT individuals and people living with HIV, and in reality, as you can see on this slide, nearly half of our patients identify as heterosexual, and only about 50% of our annual medical visits are HIV related. We are very proud to report that our medical statistics demonstrate high quality of care indicators. Our indicators in diabetes and hypertension related care in particular exceed national benchmarks, which is something we're very, very pleased about. And in addition to providing all of the traditional services that we do offer, we aim to improve the health of the communities we serve by expanding our program offerings to focus on our patients' overall health outcomes. And as an adjunct to some of the traditional health services I mentioned, Whitman Walker Health launched a host of integrated wellness program offerings in 2013, one of which was the American Lung Association's Freedom from Smoking program, which is evidence-based and focused on positive behavior change. Currently, 3 of our members of our community health and wellness staff are certified to facilitate the Freedom from Smoking program, and we offer it both on-site at 2 of our locations and off-site at partnering community-based organizations. And since we launched the program in late 2013, we've provided the Freedom from Smoking program to 45 patients of Whitman Walker Health and 25 clients of partnering community-based organizations. So a little bit about the Freedom from Smoking program. For the past 25 years, this program has been updated and improved several times, and it's often referred to as the gold standard in smoking cessation programs. And one of the things I appreciate the most about it is that they recognize that no single method works for everyone. And throughout the 8-week clinic, we employ a number of different methods to meet participants where they are and provide them with personalized tools and concrete strategies to help them quit smoking or reduce their tobacco use. So we do operate with a harm reduction method when necessary. And the Freedom from Smoking model is based on the Stages of Change model, which is a tested and respected system for bringing about positive behavior change. And in addition, the program builds on participants' experiences from past quit attempts. So rather than looking at those as failures, we work to help people see these things as learning opportunities where they picked up skills that will ultimately be effective in the long run in meeting their goal. And more importantly, it uses a relationship-based supportive group setting to really facilitate mutual aid between participants who are all working toward the same goal. And with that, it's my pleasure to turn it over to Mandy to discuss some of our program evaluation.
Thank you so much. Thank you. I'm pleased to be here today to talk to you about our evaluation of the Whitman Walker Health Tobacco Cessation Program. This was funded by a DC Community Health Administration Public Health Block Grant, and so I wanted to disclose that. And I also wanted to just acknowledge again Whitman Walker as a partner on this and inviting us to partner with them on this project to try to continually improve the tobacco cessation services that they were beginning to offer, and also in wanting to disseminate our findings as we learn to the rest of you, to the wider community, so that we can try to learn together and improve what we're doing collectively. So after I present today, what I'd like you to take away is being able to summarize 3 tobacco cessation program recommendations for each of the special populations that I'll be talking about today, being able to discuss a possible evaluation strategy to apply to your own program, and identify possible solutions to challenges with participant retention and sustained quit attempts that might be applied to the work that you do. So the project, again, was the result of a partnership between the GW Cancer Institute and Whitman Walker Health. In 2014, Whitman Walker Health received a grant from the DC Department of Health to deliver tobacco cessation programs at Whitman Walker Health and at community partner sites. And we, as the evaluation partner, were tasked with translating evidence into practice improvements. So taking what we could find out about what's currently going on in practice and the evaluation we could do with their program to try to shape some program improvements and impact. Past challenges to successful cessation programs at Whitman Walker Health included limited class retention and few sustained quit attempts. So we were given that information up front. As Amy previously described, the tobacco cessation program at Whitman Walker Health was adapted from the American Lung Association's Freedom from Smoking program, and this is an evidence-based program designed to be delivered in a small group clinic setting, and it includes 8 sessions, as Amy mentioned, and it features a step-by-step plan for quitting smoking. Whitman Walker Health used the Freedom from Smoking teaching materials, but some sessions were delivered one-on-one or on an extended timeline because of attendance or the logistical needs of participants, as Amy mentioned, in order to tailor to the specific needs of their program participants. So what we wanted to do in our evaluation, primarily Whitman Walker wanted to know how to improve the program and increase enrollment and retention, and they also wanted recommendations for increasing sustained quit attempts. So we took a mixed methods approach to the evaluation, beginning with a literature review and involving both pre-post surveys as well as focus groups. And so I'll talk to you a little bit about each of these things as we go along. The literature review focused on the unique needs of populations specifically served by Whitman Walker and their community partners. So we took a look at evidence we could find with people living with HIV, lesbian, gay, bisexual, transgender, and queer questioning individuals, homeless individuals, and African American individuals, all of whom are a high proportion of the folks that Whitman Walker serves. According to the American Legacy Foundation, certain racial ethnic groups LGBTQ individuals, people with mental illness, and others are likely to initiate tobacco use more often and may struggle to quit smoking. And these groups often have poorer access to cessation services. They're also more likely to suffer from tobacco-related disease and death. So our literature review was conducted in October of 2014, and we used Medline and Scopus for the review. Systematic analyses and Cochrane reviews were included where we could, where they were relevant, and the following combination searches were used. We used search terms smoking cessation, clinical intervention, cigarette, nicotine, community, and barriers to access. And then we refined the searches by filtering by specific subpopulations of interest, including African American or Black, homeless, Hispanic, Latino, LGBT or lesbian, gay, bisexual, transgender, and sexual minorities, and HIV positive or HIV infected. And we reviewed a total of 113 peer-reviewed published articles. So the factors we found that impacted the success of interventions and should be kept in mind when adapting a smoking cessation intervention included the following. Individuals with comorbidities such as psychiatric or substance abuse disorders may have less success on a standard program and require more specialized strategies. In addition, the level of nicotine dependence is a factor in attempting to quit and sustaining abstinence. Assessing readiness for change and adapting interventions to meet the stage of change of the participant was shown to be a critical factor in individual success. And finally, tailoring interventions to the unique needs and cultural considerations of specific populations can also lead to greater success. And as you saw in the rotating slides at the beginning and Aubrey mentioned, there's a PDF of the Lit Review available for download in the pod section of the presentation if you'd like to access that. You can also get to that kind of indirectly from our website, but this is a lot easier to just download it from the podcast. From the files in the pod. So now we're going to look at the different subpopulations specifically that we looked at in the literature review. In terms of people living with HIV, we found that people living with HIV are twice as likely to smoke as the general population, and this may be related to multiple factors such as stress and risk perception. Analysis of focus group of HIV-positive men by Reynolds in 2004 indicated that HIV-positive smokers are under the impression that smoking would not have a negative impact because they would not live long enough to experience the adverse consequences that would come from smoking. Obviously, that was over 10 years ago, and with advances in HIV care, this perception could very well be changing. In addition, the literature showed that decreasing the prevalence of smoking among HIV-positive individuals could increase survival time. Smoking is associated with HIV and AIDS-related diseases such as pulmonary infections, oral diseases, cardiovascular disease, and cancer malignancies. A study by Mamry and his colleagues in 2002 and Wallace and colleagues in 1997 noted that HIV-positive smokers are at a greater risk for developing bacterial pneumonia, oral lesions, and AIDS dementia complex than non-smokers. Generally, the studies reviewed for this population were small pilot tests of clinic-based interventions. From our review, we would make the following recommendations for tobacco cessation programs specifically for individuals living with HIV, with the caveat that, again, these were small pilot tests and there wasn't a breadth of rigorous research available for these recommendations. Addressing psychosocial barriers to cessation is important, routinely assessing smoking status and readiness to quit, monitoring progress to prevent relapse, and increasing clinical education on tailored interventions for smokers who are HIV positive. For LGBTQ individuals, the 2013 National Health Interview Survey assessed health disparities in sexual minority groups, and this study found that there were a higher percentage of people who identify as gay or lesbian or bisexual who smoke compared to their straight counterparts. So about 27 or 29% for gay and bi populations compared to just below 20% for straight counterparts. And the differences were not significant among men aged 18 to 64, but lesbian and bisexual women had a significantly higher smoking prevalence compared to straight women. According to the minority stress model, stress and sexual stigma play a role in negative emotions and stress, leading to smoking and relapse in LGBTQ populations. According to a study by Dilley and colleagues, LGBT groups have been targeted by the tobacco industry's media campaigns and marketing strategies. And the American Legacy Foundation discovered that tobacco companies had a project titled a Subculture Urban Marketing Campaign that was specifically aimed at gay and homeless people. So some of our recommendations in response to these findings were that, while we didn't have any randomized controlled trials of tobacco cessation interventions in this group, and there was data lacking in that area, we have smoking cessation classes that have been adapted for the LGBT community in the literature, and we pulled these recommendations as follows. Intervention should specifically counteract smoking ads targeted at LGBTQ populations, so we know there's a concerted effort on the part of tobacco companies to target this population, so specifically countering those messages is very important. Incorporating culturally specific content, such as the role of smoking in LGBTQ culture, stress, social support, bar culture, and smoking, as well as hormone use, can be really important to this population, and maintaining sensitivity towards culturally specific challenges when discussing tobacco cessation can be helpful. In terms of homeless individuals, it's hard to get an accurate measure of smoking prevalence among homeless persons for data collection reasons, but the National Coalition for the Homeless has estimated that 70% of homeless adults smoke compared to 20% in the general population. Lack of insurance, poor hygiene, unstable housing, food insecurity, and risky behaviors can put homeless adults at a greater risk of tobacco-related medical conditions like cancer, respiratory illness, and cardiovascular disease. Lack of access to health care resources, lack of transportation, and inability to afford nicotine replacement therapy are serious barriers to smoking cessation success in this population. So, again, what we could find in the literature based on what was available, we identified these recommendations for smoking cessation for homeless persons. Using counseling and nicotine replacement therapy or medication to assist with cessation, as well as continuous in-person engagement. We found that in-person interventions were better received than nicotine replacement therapy alone. As you can imagine, in-person engagement can be difficult given the transportation barriers, so transportation assistance may also be necessary, and incentives may be helpful. Relationship-based approaches, that's also in line with the in-person engagement, were more effective than phone-based services. And presenting information that's relevant to the lifestyle of someone who's homeless is important, so providing strategies that someone can actually incorporate and implement responsive to what is going on in their life is important to keep in mind. And then finally, for the African American subpopulation that we looked at, clearly these different populations have overlap, and this is fairly rudimentary, but we're trying to start somewhere. According to data from the Centers for Disease Control and Prevention, the percentage of African Americans who smoke is slightly less than other groups, actually, including white Americans, multiple race Americans, and American Indian groups. However, African Americans are less likely to receive cessation interventions and are less informed about the health consequences of smoking. They may make more attempts to quit and are likely less successful when they do try to quit compared to non-Hispanic white counterparts. And these factors contribute to higher smoking-related mortality, according to a report by the California Department of Health Services. Also, African Americans are more likely to smoke mentholated cigarettes, which are higher in tar and nicotine. So when we're looking at our recommendations for this population, addressing the effects of menthol was one of the things that we recommended, in addition to increasing health education to improve awareness of negative impacts of smoking within this population, and combining self-help interventions with telephone counseling. So after our literature review, after we had a better understanding of general recommendations that the evidence base currently had for these special populations, we wanted to move on. I'll talk to you now about our specific evaluation of the Whitman-Walker tobacco cessation program using pre-post surveys and focus groups. And this was definitely a real-world evaluation, so this was not done in a lab, and you will see that it can be difficult to generalize data, but it still can be helpful in specifically understanding the experiences of those going through the program, and important insights, I think, were gleaned. So to evaluate the impact of Whitman-Walker Health's smoking cessation program, we designed a pre-post questionnaire to determine the impact of the smoking cessation classes on attitudes towards smoking and smoking behavior. We had a 19-item pre-test and 15-item post-test tailored to address the evaluation goals of the project, and we adapted validated scales and concepts where we could, including the PROMIS nicotine-dependent short form, the PROMIS coping expectancy short form, point prevalence abstinence, and length of smoking abstinence. And several questions used a Likert-type scale, with 0 meaning never or not at all, and 4 meaning always or very much. Surveys were collected from all tobacco cessation program participants at Whitman-Walker Health and partner sites. The pre-test was designed to be completed at the beginning of the first session of the program, and the post-test was to be completed at the end of the final session. As I'm sure all of you know who have done evaluation and those who have done research, it can be challenging to make sure that you're going through all of the hoops in a timely fashion, and in order to get our IRB approval, based on the timing of the program sessions, not all program participants completed a pre-test before beginning the program. So we collectively decided it was more important to start the intervention and get the pre-test that we could once the IRB approval came through, rather than waiting for the intervention. And additionally, because of the number of dropouts, not all pre-tests have a matching post-test. So, some survey results. In total, 18 tobacco cessation program participants completed pre- or post-tests, and the majority of participants were Black or African American men aged between 50 and 64 with varying education levels. 1 participant identified as transgender, 5 as gay or lesbian, and 2 as bisexual. Participants reported initiating tobacco use at an average of 14 years old and had been using tobacco for about 35 years. Let's look first at survey results on the overall sample of 18 participants. When comparing group average scores between the pre- and post-program responses, it would appear that there was a decrease in the number of cigarettes smoked each day, number of days they smoked, and an increase in time gone without smoking, as well as delay in smoking the first cigarette of the day. But do remember that there may be individuals who completed a post-test who did not complete a pre-test, and vice versa. So these are general conclusions, but we can't be completely sure that they're completely accurate based on the limited data that we had. So continuing to review unmatched group averages from pre to post, it appears that there were slight decreases in all of these behavioral indicators suggesting better control of the smoking habit. So this included reaching for cigarettes without thinking about it less frequently, less often dropping everything to go out and buy cigarettes, less frequently smoking before going into a situation where smoking was not allowed, reduced intolerable cravings when they hadn't been able to smoke for a few hours, less frequent cigarette use to calm themselves down when angry, less tempted to smoke when feeling depressed, less reliance on smoking to deal with stress, and less reliance on smoking to take a break from problems. So all of that is very positive. And again, looking at the unmatched group averages, we see that there were slight decreases rather than expected increases in interest in quitting, motivation for quitting, committing to quitting, and confidence in quitting. So again, the data are limited, and this is what the numbers show. The results may or not reflect actual program effect based on the limited matching data, and it might be also the result of a response pattern where the questions use the same scale as prior questions, but the positive response would have been toward very much or always, where previous questions would have been toward not at all or never. So respondents may have not realized they needed to answer differently. That is a possibility. Notably, at both pre- and post time points, at least 2 individuals felt that their partner or family did not want them to quit, and 2 also reported that friends or coworkers did not want them to quit. Of the 18 total survey respondents, there were only 8 that matched from pre to post. And results from a Wilcoxon-signed rank test, and that's the non-parametric version of a paired t-test used when the sample size is less than 30,
This supported a downward trend in some key tobacco perceptions and behaviors, including an overall tobacco use in those completing the post-surveys compared to pre-test results. Though not a statistically significant decrease, the average number of cigarettes smoked in the past 30 days dropped from 20 to 14 among 3 matched pre- and post-test respondents. Generally, participants seemed to express greater ability to cope with anger, depression, stress, and cravings after completing the tobacco cessation program. However, due to the lack of matched questionnaires, conclusions are obviously limited. Even for matched pre- and post questionnaires, not all respondents replied to every question, so the number of respondents is noted in parentheses. There was a statistically significant decrease in the impulse to reach for cigarettes without thinking, dropping a whole point on a 4-point scale. Marginally significant decreases were also seen in level of intolerable cravings and the impulse to drop everything to go and purchase cigarettes. Notably, there was no average increase in motivation to quit smoking because 3 respondents reported higher motivation, 3 reported lower motivation, and 2 did not change motivation level from pre to post. Because of the small sample size and because program evaluation and improvement often benefits substantially from capturing participant feedback, we also conducted focus groups in addition to the pre-post surveys to triangulate our findings before making program recommendations. The focus group guide was developed based on the health belief model and to help answer our evaluation questions about increasing enrollment and retention and increasing sustained quit attempts. We conducted 2 focus groups and 2 individual interviews in addition to the pre-post survey. The 3 groups included past participants who did not complete the program or dropouts, current or former participants who did complete the program, completers, and 2 interviews with individuals who enrolled in the program but did not attend any classes, no-shows. And this 3rd group was planned to be conducted as a focus group, but because the confirmed participants did not arrive at the same time, we actually conducted them as individual interviews following the focus group guide outlined on the slide. 10 individuals participated in this portion of our evaluation. The first focus group in December of 2014 included 5 past program participants who had not completed the full program. 2 were not currently smoking. The second focus group included 3 individuals who were currently enrolled in the Whitman-Walker Health Cessation Program or had completed the program. 1 person was not currently smoking. The final group of individuals who had enrolled in the smoking cessation program but never attended a class, these were the 2 individuals who participated as individual interviews, but we analyzed together as we would a focus group. So across the group, similar reasons for smoking were cited, including stress, habit, and the influence of alcohol. One smoker said, "That's another excuse to smoke a cigarette. You know, smoking is not going to make things better, but it definitely calms down the nerves." Another smoker said, "It's the stress reliever, it's the calm that lets me get away and float away from the problem for a moment or just ignore it and enjoy my cigarette." Smoking as a habit was frequently referenced in the completed or currently enrolled group and the group that did not attend the program, whereas smoking as a choice was emphasized in the group that did not complete the course. For example, one smoker enrolled in the tobacco cessation program said, "I mean, after I eat, just watching TV, you know, it's just one of the hardest things to stop. It's just all the effort to just say no. You know, it's a bad habit." Another focus group participant who did not complete the program emphasized choice. "I'm in a struggle with it because I'm not going to lie. Every once in a while, for the same reason of just not wanting to let go of everything that I do, I'll pick up a cigarette." Costs of smoking mentioned by the participants included financial costs of cigarettes, health costs, and personal costs. The issue of breath and clothing smell came up a lot here under social costs and time, as well as social costs and time costs. So in terms of health, one participant said, "I say it like this, you know, when you smoke a cigarette, it definitely changes your physical ability to do things. When you're walking or you're trying to run or you're trying to beat the light or something like that, you're totally out of breath. Those are the things that I know that I need to kind of look at." Another person said, "I didn't realize how much I spent on cigarettes and planning my life around having a pack of cigarettes, you know, days when you're scrounging through the piggy bank to find pennies to go and get a pack of cigarettes." A third participant said, "My pockets stay emptier because of the cost of cigarettes. I mean, the cost is almost $7 a pack, and so when I smoke, I'm spending $40 to $50 a week on cigarettes, even when I don't have it." Personal costs, such as the smell of cigarettes on breath and clothes, were also commonly referenced. One participant said, I cannot stand the smell of it. I can't stand the taste of it. There's candy in all of my pockets. In every room there's air fresheners. Another person said, I know what it smells like, especially secondhand smoke. It stinks, you know, and I tell myself this is a stinking, ugly, dirty, funky habit. Most participants cited the social cost of smoking, whereas one participant identified smoking as something of a social benefit. In terms of cost, you're almost an outcast if you're a smoker, just the way people look at you. I'm not trying to do anything, but just the look that people give you, it's just that disgust. And in terms of benefits of changing, a sense of accomplishment was important. One participant said, I actually feel good about who I am and having overcome this giant of a monster that's been holding me down and killing me and bankrupting me and chasing everybody else away from me because I stink. I mean, it's a good feeling to know I can still accomplish something. So in terms of the barriers noted to quitting, these included cravings, stressful life events, stress came up a lot, weight gain came up a lot, and the influence of smoking and quitting smoking on mood. One person said, well, the biggest worry for me is weight gain. When I first started the group, I just literally dropped from like a pack a day to smoking 2 cigarettes a day. But I was eating everything around me, and I noticed I started to pick up weight, and that is just such an issue for me. Another person said, I was doing good. It's like every time I try to quit, it's like something comes up, death in the family, or I didn't have a job for a minute, and I was just like stressing. And so those are the things that make me upset. And finally, a third person said, I'm an addict. I'm always doing something in excess, so it's not the cigarettes, it's me. Whatever the problem is, it's me. In terms of facilitators for quitting, exercise, meditation, and alternative stress reduction techniques were seen as helpful. They also felt that creating obstacles to smoking, such as removing ashtrays from the home, was very helpful. In terms of efficacy, determination and choice to quit were major themes. One person said, and I said to myself, well, I need to do something different, and so what I did different was I stopped smoking. Another person said that what was most needed was coming out of my denial, that when I say I want to stop smoking, that is what I mean, not saying that I want to stop smoking because it sounds fashionable, but because it's what I want to do. Some smokers felt that policies that restricted smoking to outside were strong deterrents, especially when it was cold outside. However, some smokers stated that a smoker is going to find a way to smoke. And one person said, you find a way, I do. I will catch a cold just to have a cigarette. And another smoker found, which I mentioned before, found a social benefit in having to go outside to meet and chat with other smokers. He said, when you're at a club and everyone has to go outside and smoke, that was the thing where it seems like you could really meet people when you're in a crowd of smokers. When you go outside and that group is smoking, you all get into some kind of friendship. So limitations of the evaluation. There were several limitations to robust data collection for the project, which limits the conclusions that we can make. As was a known concern at the outset and the impetus for the study, regular attendance and program retention was a challenge. This contributed to a small sample size for pre-post tests and even smaller number of pre-post tests that could be matched to the same participant. Additionally, because of a delay in IRB approval and the desire on the part of Whitman Walker Health and their partners to begin program sessions on time, several of our pre-tests were not completed at the very beginning of the fall session, possibly not representing a true baseline. And the aim was to recruit 6 to 8 participants for each of the 3 focus groups, and we had 5 to 6 folks confirmed for each, but fewer actually showed up. So the general sample who ended up participating in surveys and focus groups appears to represent the general population served by Whitman Walker Health, but the data collected is not truly generalizable beyond study participants or to a broader population. And though the survey was developed based on previously validated measures and scales, there was not time to pilot test it with an audience. So many questions had open-ended write-in answers, and standardized data analysis was difficult. Some questions may have also been misinterpreted by respondents. For example, a person who reported successfully quitting smoking might not have known how to answer the questions about motivation and commitment to quit. For respondents who primarily use cigars or other tobacco, many questions were not explicitly applicable because they specifically referenced cigarettes. And some data that were outside a reasonable range had to be discarded. So, for example, in the last 30 days, participants stated he had smoked 700 days. Moving forward, further validation and standardization of measures and pilot testing with the intended audience could yield more meaningful data. And finally, despite being de-identified questionnaires, self-report data may have been biased by responding towards socially desirable answers. But despite these limitations, the information gathered through this program evaluation and literature review resulted in rich insights and recommendations for program improvements, which we felt were really important as feedback from the participants themselves. And we hope that they will help to enhance participant retention and success with the tobacco cessation services at Whitman Walker Health. So the results of this evaluation show that Whitman Walker Health tobacco cessation program participants on average start smoking in their early teens and have smoked for decades, likely making sustained abstinence a substantial challenge for many. And despite the small sample size, 4 participants in the focus groups reported reduction in smoking as a result of the program, and program participants also indicated reductions in smoking behavior and a greater ability to cope with anger, depression, stress, and cravings on the post-test after completing the tobacco cessation program. Improvements in retention and program tailoring have the potential to make broader, more sustained impact on the health of this community. The results from the literature review, focus groups, and survey line up in a few key ways. So the barriers to tobacco cessation success identified in the literature review overlapped with those brought up by focus group participants, namely readiness for change and the need for tailored interventions. Focus group participants discussed their success in quitting being tied to a belief in their personal ability to do so, and those in the did not complete group in particular discussed smoking as a choice and simply not being ready to quit. These same participants who did not complete the program focused on the history of addiction to tobacco and other substances more so than those in the other focus groups, a factor that was clearly identified in the literature as a hindrance to sustained abstinence. Assessment of level of readiness to change and level of nicotine dependence up front could help identify participants who need additional time and attention before making a serious quit attempt. Specific barriers identified by focus group participants included stress, fear of weight gain and mood changes, and cravings, while facilitators mentioned included alternative stress reduction techniques, exercise, and provision of nicotine replacement therapies. Knowing these common challenges, the Whitman Walker Health Program can be tailored to provide specific actionable strategies to prepare participants for dealing with these anticipated challenges. And the program could be expanded to incorporate additional activities. Further, recommendations to improve retention directly from participants included adding a goal-setting component and a financial incentive to complete the 8-week program. The appreciation for and value of social support and non-judgmental accountability offered by Whitman Walker Health Tobacco Cessation Program came up in every focus group, and this support is a clear facilitator to quit attempts. The program facilitators should maintain their approach in setting a tone of openness, support, acceptance, and encouragement. The survey showed that at least 2 participants had family members or other loved ones that did not want them to quit. In these instances, it will likely be especially important to engage those participants in the accountability and support by providing additional strategies for sustaining quit progress at home. As one focus group participant explained, introducing current participants to successful past participants will show that success is possible in someone they can identify with, and it will reinforce the sustained abstinence of the past participant, helping to build a network of former smokers and provide additional channels of social support. And just in summary, based on the analysis of the literature review and our quantitative and qualitative data, we made the following recommendations. Tailor program content based on individual and group characteristics such as race, ethnicity, sexual orientation, HIV status, and socioeconomic status. Also acknowledge the reasons why participants quit and identify personal cues to action and benefits like improving health, saving money, and accomplishing something difficult. Participants identified a true desire to quit, and self-motivation was important to success. So using a screening interview to determine a true desire to quit and identifying perceived self-efficacy could help with program retention and quit attempts. Including stress reduction techniques such as yoga and meditation, and a variety of activities in the course curriculum to sustain interest and help identify alternative stress relievers was mentioned by quite a few people in terms of needing some kind of alternate channel to relieve their stress. Smoking may just be one symptom of other physical or psychosocial issues for a client, so addressing confounding factors that contribute to stress may lead to greater success. Also, helping participants identify prohibitive environments that connect them to non-smokers can replace smoking for enjoyment. And encouraging participants, even if they have setbacks, was really appreciated and highly noted and something that should be maintained. Allowing successful quitters to share experiences to reinforce success and inspire others is a way to give back and reinforce each other. Facilitating social support and accountability. And multiple pharmaceutical or nicotine replacement therapy interventions may need to be tried to find one that best supports individual efforts. So facilitating access to these therapies to support quit attempts is important, and trying alternates. I know a number of focus group participants said that nicotine replacement therapy didn't work for them, or they didn't try it, but trying a number of different options and approaches is important. Reinforcing available local and national resources to support sustained quitting can also be very helpful. So that is what I have to share with you today. This was my team. It would not have been possible without the awesome folks at Whitman Walker Health delivering the program and helping us make some decisions about evaluation at key points at inception and throughout the process. And Aubrey, Liz, and Hira on my team were instrumental to helping with data collection and analysis and dissemination. So I want to thank them as well. If you want to have access to the references that I noted, we have them listed on the slides, and those are available in the download section if you want to reference anything that I cited. And if you have any questions, this is my contact information. So at this point, I think we're going to take any questions.
Thank you so much, Mandy and Amy, for sharing with us. We are now going to open up for participant question and answers. So if anyone has questions that they would like to submit, please use the question answer pod that's now at the top right of your screen. And again, I just want to thank you, Mandy. I want to also mention that down in the downloads pod is the final version of our literature review. Mandy presented the highlight of the results from that, but there are additional references there, and you'll find references of programs that have been validated and tested across the country for cessation in different populations. You'll also see a helpful links pod, and you can, the first one in the list there is a link to Whitman Walker's wellness services that they offer at their clinic. You can also see the American Lung Association Freedom from Smoking program and Freedom from Smoking Online, as well as a link to our evaluation survey for today's webinar. So if you'd like to fill that out, you can click on that and start that now, or when we end the meeting, that will come up automatically. So I'll just give people a second here to type in any additional questions if anyone has any. You can see here on this slide that our website is cancercontroltap.org. That is where we house all of our technical assistance resources for cancer control. And we would love to have you subscribe to our monthly technical assistance e-newsletter via our website and get up-to-date news on new resources that we put out, online training and events, and other cancer control news. You can also follow us on Twitter at GWCancerInst or email us at cancercontrol@gwu.edu. And you saw a number of things in the lobby when you were waiting to start the webinar. We've recently released a few new resources that I'll just quickly mention. One is the Breast Cancer Awareness Month Social Media Toolkit, and that toolkit is useful for a number of things. It includes a whole calendar of messages for Twitter and Facebook that you can use to raise awareness about breast cancer if that's something that your organization focuses on, and that is now available on our website for download, and so that you can go through the process of getting it approved at your organization and get that ready to push out for October 2015. We also are currently conducting a very brief 10-question annual survey for technical assistance needs. So if you work in cancer control and want to share with us any additional topics or activities as we plan our next years, please feel free to fill that out. And we'll make sure that you have all of these links in the email that we send at the follow-up to this webinar. A question came in here for I guess Amy or Mandy could field this. How many federally qualified health centers do you think actually have proactive programs like this? Thoughts on that, Amy, maybe?
You know, I can't speak too broadly about how the number of FQHCs across the U.S. that are implementing proactive programs like Freedom from Smoking, but I do know that a lot of community health centers and FQHCs are moving toward a more integrated health and wellness model. So in addition to, you know, traditional medical and behavioral health services, we're looking to identify issues that are affecting people's lives like tobacco use and working to address those issues rather than waiting for problems to arise as a result of those behaviors.
Okay, thank you for that, Amy. So we haven't gotten any additional questions in, so I think what we'll do is wrap it up. I want to take a moment to thank everybody for being here with us today, thank our speakers again.
There was one question I saw that asked if you provided financial incentives to the participants, which I believe the answer is no, Amy?
Correct.
So sorry, I saw that one and I wanted to just address it since it was up there. Sorry to cut you off, Aubrey.
No, that's great. We cannot see that question on our end, so thank you for addressing that, Mandy. And if there's no other questions, I will give you all back 10 minutes to your day. Thank you so much for joining us, and please help us out by filling out the evaluation survey on your way out. Thank you.
Thank you so much.